is 6:30. Good morning, everyone. Another Monday with lot of knowledge, and today we will learn what exactly we should be knowing about fentanyl. And for this, today's speaker is Dr. Revathy. Dr. Revathy is our junior resident in the Department of Palliative Medicine, and she is working in the area of what are the patients' palliative care needs of patients when presenting in emergency department. Today she will be talking about fentanyl, and her lecture will be moderated by Swati. So Dr. Swati is our department assistant professor, one of the most sincere and very organized person of the department. She has got a lot of talents, and whatever we ask her, and whenever I have seen her with the patient, she really gives holistic treatment or holistic approach. Her approach is holistic. So today we will see what exactly they have brought us in as far as fentanyl is concerned. What are the latest evidence and guidelines of fentanyl uses? And what I will suggest that everybody should write their comments or questions in the chat box. And after the lecture, we will take all the questions one by one. So Revathy, you can start. Thank you. Revathy, you can start sharing the screen.
Yes, ma'am. Yes, ma'am. Ma'am, is it visible?
Yeah, it's visible and you are audible also. But yeah.
Okay.
Good.
Thank you, ma'am, for the introduction. Good morning, everyone. Today, I am going to discuss, my presentation is on the topic fentanyl. I'm doing my junior residency in the Department of Palliative Medicine in BRA-IRCH, James Delhi, and my presentation is being moderated by Swati Bhan. She is the assistant professor of the Department of Pharmacokinetics and Palliative Medicine. Introduction. Fentanyl is a potent synthetic opioid, which is around 50 to 100 times more potent than morphine. It belongs to the class of strong opioid analgesic with a chemical structure of phenylpiperidine. It is a Schedule 2 prescription drug, which means that it is a drug which has a high potential for abuse and dependency, that is both physiological and psychological dependence. It is mainly used for the management of severe pain and also as an adjuvant in anesthesia. It is a part of the IAPC list of essential medications for palliative care. The history of fentanyl. It was first synthesized by Belgian physician Paul Janssen in 1959. By 1968, it was started being used as a general anesthetic. The transdermal fentanyl patch, which we know as of now and regularly used in our palliative care setup, has been developed by mid-1990s, and around 1998, the fentanyl citrate lollipop was introduced, and the fentanyl soluble buccal film was approved for use by the US FDA around in 2009. Coming on to opioid receptors, if we have to know what the action of fentanyl we need to know about the various opioid receptors. We have mainly mu, kappa, and delta opioid receptors, and also a newly found opioid receptor, the ORL1. The mu opioid receptor is located at sites of peripheral inflammation in brain, in spinal cord at the pre- and post-synaptic neurons, and also in the submucosal and mesenteric plexus of the GI. It will result in clinical effects such as analgesia, respiratory depression, meiosis, euphoria and physical dependence, and also decreased GI motility. The kappa opioid receptor is found in the mesenteric plexus, brain, and spinal cord. It will result in analgesia, dysphoria, psychotomimetic effects, meiosis, and respiratory depression. The delta opioid receptors are found in mesenteric plexus and brain. This will give forth central anesthesia and central analgesia, and also will result in decreased GI motility. The ORL1 receptor is mainly found in the spinal cord, and it has been found to further research is to be done regarding the exact function of ORL1 receptor, but it is found to have various action on modulation of biological functions, various biological functions such as memory, movement, and also stress responses as such. And among these opioid receptors, fentanyl has the highest affinity to mu opioid receptor, which we can see as depicted in the image. It has the highest affinity to mu opioid receptor and some affinity to kappa and delta opioid receptors as well. Opioid classification based on the agonistic action on the opioid receptor. Opioids can be classified as strong agonist, moderate agonist, weak agonist, and mixed agonist and antagonist. Among this, fentanyl is a strong agonist because it has very high affinity to the mu opioid receptor. Coming on to the pain ascending pathway. The ascending pathway of pain from the site of nociception, the peripheral nerves will carry the sensation of pain, and it is the first order neuron is located in the dorsal root ganglion in the spinal cord, and the sensation is carried up and above via the spinal cord through the medulla, midbrain, and finally reaches the somatosensory cortex. Various drugs that help in inhibiting ascending pain transmission and thereby resulting in analgesia include acetaminophen, NSAIDs, lidocaine, capsaicin, menthol, and also opioids. Fentanyl, which comes under opioids that we are discussing today. The mechanism of action of fentanyl. Fentanyl is a mu selective opioid agonist. It has also some or little action on the kappa and delta opioid receptors. And we have to know that all opioids are G protein coupled receptors. So what happens at the level of the opioid receptor? Fentanyl binds at the mu opioid receptor and will result in a decreased cyclic AMP production, decreased calcium ion influx, and increased potassium efflux, which results in the inhibition of ascending pain pathway. This in turn will cause a decreased perception of pain by increasing the pain threshold. This is what happens at the level once fentanyl binds to the mu opioid receptor. So what happens inside the cell? Once there is a decreased intracellular calcium, it will result in a decreased release of dopamine, serotonin, and also various nociceptive peptides such as substance P, resulting in the blocking of the nociceptive transmission, thereby resulting in analgesia. Here we can see the G protein coupled receptors, and the substrate binds extracellularly to the G protein coupled receptor, and there will be an acute adenyl cyclase inhibition, which will result in decreased CMP production and decreased calcium ion influx, thereby resulting in analgesia. And this will also have various other effects such as respiratory depression and constipation also. The pharmacokinetics of fentanyl. It is a basic drug which has very high lipophilicity, and around 90% of the drug is found bound to protein. It is metabolized by the CYP3A4 enzyme, which is included in the CYP450 enzyme system. The metabolite of fentanyl is norfentanyl, which is an inactive metabolite. This means that norfentanyl does not have any pharmacological action on any of the organ systems. It is around 7 to 10% of fentanyl is excreted unchanged in urine, and it has an average half-life ranging from 2 to 7 hours. The properties of fentanyl, such as the high lipid solubility, the protonated state at which it exists in the physiological pH, and also the high protein bound state, results in the rapid crossing of cell membranes, and also this is the reason for the immediate onset of action of fentanyl. The pharmacodynamics of fentanyl. Fentanyl receptor, it has the highest affinity to mu opioid receptor, as we have discussed already. The antagonist of fentanyl is naloxone, which is a synthetic morphine derivative. And on comparing with oral morphine, potency can be graded as for 30 milligrams per 24 hours of peroral morphine, the equivalent transdermal fentanyl is 12 micrograms per hour, and the equivalent subcutaneous or IV fentanyl dose in micrograms per 24 hours is around 300 micrograms. Similarly, for each peroral dose of morphine in milligrams per 24 hours, there is an equivalent dose of fentanyl in transdermal and also subcutaneous and IV route of administration. the action of fentanyl on the central nervous system. In the central nervous system, in the brain and the spinal cord, fentanyl will act on the mu opioid receptors, resulting in analgesia, as we have already discussed. But it also has other actions, such as it induces euphoria and sleep, and also it might result in the disruption of REM sleep. It also has various effects on the hypothalamus. It will result in the release of hormones from the pituitary and hypothalamus. Fentanyl will act on various receptors on the hypothalamus, thereby resulting in a decreased dopamine release, which in turn will cause an increased prolactin release. And one of the other main action is that it acts on the supraoptic nucleus of the hypothalamus and results in increased ADH release, that is increased vasopressin release. All of this is the action on central nervous system, but the outcomes will result in various changes in the endocrine system. Fentanyl will also act on the Edinger-Westphal nucleus in the cortex, which will result in meiosis, a pinpoint nucleus. This is an action of fentanyl which does not develop tolerance at any time, and therefore it is also diagnostic of the use and abuse of fentanyl. Fentanyl also has action on the opioid receptors in the medulla. It will depress respiration by acting through the mu2 receptors. This action has no tolerance at all. What happens is it acts on the mu2 receptor and causes respiratory depression by decreasing the sensitivity of the medullary receptors to concentrations of carbon dioxide and also respiratory rate. But however, it does not have any effect on the sensitivity of medulla to hypoxia. It also acts in the chemoreceptor trigger zone area posterior in the medulla and will result in opioid-induced vomiting. However, this action has tolerance. That is, over time, the patient will develop tolerance to opioid-induced vomiting. Fentanyl action on gastrointestinal system. Fentanyl will increase the sphincter tone and it will decrease the gastrointestinal motility, and it also results in the parasympathetic release of acetylcholine. All this will together result in the reduced absorption of drugs from the GI tract and will also result in constipation. The increased sphincter tone will result in the constriction of various sphincters, which can cause biliary colic and other GI distress in a patient who is administered with fentanyl. The action on the cardiovascular system. Fentanyl will act on the vagal nucleus, and it will result in increased vagal nerve tone and thereby increases the parasympathetic drive and will also thereby cause bradycardia. It also slows the vasomotor centers in the brainstem and will result in vasodilatation. There is high risk for vasodilatation in patients with hypertension and congestive heart failure because these patients will already have an increased sympathetic drive. Action of fentanyl on immune system. It will affect the function of the T helper cells and the T suppressor cells and thereby results in immunosuppression. It also results in histamine release from a variety of immune cells, thereby resulting in a phenomenon of itching. It might result in itching. Various drug interactions of fentanyl. The fentanyl plasma concentration is increased by CYP3A4 inhibitors, as we have already seen that it is metabolized by the CYP3A4 enzyme. And fentanyl plasma concentration will be decreased by CYP3A4 inducers. We can see that apirapitant is both the CYP3A4 inhibitor and also an inducer. This is because in short-term use, apirapitant will increase the CYP3A4 substrate exposure, and within 2 weeks of use, it will reduce the exposure to CYP3A4 enzyme and thereby acts as an inhibitor. And other CYP3A4 inhibitors that will increase the fentanyl plasma concentration are azoles, including fluconazole and voriconazole, cimetidine, macrolide antibiotics such as clarithromycin and erythromycin, and protease inhibitors. The fentanyl plasma concentration is decreased by apirapitant, carbamazepine, phenytoin, phenobarbital, and rifampicin. The therapeutic uses. It is used as an anesthetic agent at various stages for pre-op induction, in post-operative pain, for regional anesthesia, and also epidural anesthesia. It is also used for pain management and extensively used in palliative care setup and also in end-of-life care. The common routes of administration of fentanyl. We administer fentanyl via transdermal route, through subcutaneous and intramuscular route, and also via intravenous route. These are the common routes of administration. In transdermal route, the onset of action ranges from 3 to 23 hours, and in the subcutaneous and intramuscular route, it is much shorter. The onset of action is within 7 to 15 minutes, and in IV, it is the shortest. The onset of action is within 1.5 to 2 minutes. The time to peak plasma action is around 24 to 72 hours in case of transdermal route of administration, 10 to 30 minutes in subcutaneous and intramuscular, and less than 5 minutes in IV. The plasma half-life is also similarly in transdermal 30 to 22 hours, 6 to 16 hours in subcutaneous or intramuscular, and 4 hours in IV route of administration. The duration of action in transdermal route of administration is 72 hours, 1 to 2 hours in subcutaneous and intramuscular route, and around 60 minutes in IV route of administration. Coming over to the transdermal route of administration of fentanyl. In transdermal route, the absorption occurs through the skin. This is extensive in the case of fentanyl because of its low molecular weight and the high lipid solubility. Transdermal fentanyl is available in various formulations of various doses, such as 12.5, 25, 50, 75, and 100 micrograms per hour. That is, this transdermal formulation will release the drug at this rate. What happens is, once it is available as patches, and once it is applied, the concentration of the drug in the body increases gradually. It levels off at around 12 to 24 hours and reaches a stable state and declines slowly. As we have already seen in the previous slide, the duration of action is around 72 hours. So the dosing interval for transdermal fentanyl should be in 72 hours, but there is significant inter-individual variability because of various other factors such as pharmacogenetics and pharmacogenomics that influences the metabolism of fentanyl in various individuals, and some individuals might need a lesser dosing interval that may decrease up to 48 hours. That is, they might need to change the patch in every 48 hours. And coming on to the indications for transdermal fentanyl, it is recommended in patients where the opioid requirement is stable, and it is mostly used in cases where the patient cannot be given oral morphine because of any clinical limitations or contraindications to morphine. And it is used because it is used in patients who have intolerable, undesirable effects with morphine, for example, like nausea, vomiting, constipation, and hallucination. It can be used in patients with renal failure. It is used in patients in whom oral route is not possible. That is the clinical limitation which we have mentioned earlier. And it also depends on patient preference. Here is a fentanyl patch chart wherein we can mention the patient's name and mark the site of the patch with the date of application, so that we can know where the patch has been previously applied. It is generally applied to a dry, flat, non-hairy skin on the torso or the upper arm, and it's firmly on application. It's pressed firmly in place with the hand for around 30 seconds, and the sites are rotated. Sites of application is rotated. We have two different types of transdermal fentanyl patch, a reservoir patch and a matrix patch. The major differences between reservoir patch and matrix patch is that in reservoir patch, the dose of drug released is membrane controlled. Here the drug is dissolved into a gel mixture, and it has to move through a rate limiting membrane and then to the skin. Here we can see the drug has to move through the rate limiting membrane in order to reach the skin. In the matrix patch, the drug is suspended into a solid silicone matrix, and fentanyl is in dissolved state in the adhesive matrix. Prior to giving a patient a fentanyl patch, we need to provide them as various instructions. These include the patch is to be applied on a dry, non-hairy, normal skin over flat surface of the body. The recommended sites include upper chest and arm, and it should stick to the skin completely without wrinkling, and it should be avoided on inflamed or irradiated skin, and heat should not be directly applied over the patch. The patient should avoid taking hot water tub baths, and it should not be removed and reapplied. The same patch should not be removed and reapplied, and the patch should not be cut in order to halve the dose. And also the patient should consult their doctor if they have any queries regarding these medications. the subcutaneous, intramuscular, and IV route of administration. In this route of administration, it is mostly started with a start dose of 50 to 200 micrograms, and subsequent SOS doses can be given of around 50 micrograms. The dose should be reduced in elderly and debilitated patients because fentanyl is extremely lipophilic, and fat will be reduced in these patients, so dose should be reduced in these patients. Slow IV injection will reduce the risk of complications such as muscle rigidity, and the subcutaneous route is employed mostly in end of life for management of moderate to severe pain, especially in hospice setups. Coming on to continuous subcutaneous infusion. The continuous subcutaneous infusion of fentanyl is used in the setting of mostly in the setting of end-stage renal impairment, where the eGFR is less than 30 ml per minute, and here we give an initial dose ranging from 100 to 300 micrograms per 24 hours, and SOS doses ranging from 12.5 to 25 micrograms can be given hourly. Once there is a stable pain control, the TD fentanyl patch, it can be switched to a transdermal fentanyl patch, which delivers a similar rate as that of the continuous subcutaneous infusion. Coming on to the continuous IV infusion of fentanyl. It is mostly used in case of cancer pain control. When an effective stable dose is found, it is switched to transdermal fentanyl. The patch applied should deliver the same dose as that of the continuous IV infusion, and after 6 hours of patch application, we can say average of 6 hours, but after around 5 to 8 hours of patch application, the continuous IV infusion is discontinued. Coming on to the next route of administration, the oral transmucosal fentanyl citrate. Various preparations are available for oral transmucosal fentanyl citrate, that is lozenge. There is a sublingual tablet, there is a buccal tablet, and nasal sprays are also available. In all these cases, the drug is absorbed via the transmucosal surfaces. And all of the preparations are available in various dosages. The oral transmucosal fentanyl citrate lozenge is a drug in a hardened lozenge on a stick. The method of using it, the lozenge is gently rubbed, the stick containing the lozenge is gently rubbed against the cheek until it is dissolved, and the available formulations are 200 micrograms, 400, 600, and 1200 micrograms. It is effective effective for use in breakthrough pain. In case of a fentanyl OTFC lozenge, maximum in 24 hours up to 4 times it can be used, and ideally each use should be 4 hours apart. The average time for dissolution of the drug is around 15 minutes, and the onset of action is also within 15 minutes. The duration of action ranges from 1 to 3 hours, and the bioavailability through this route of administration is 50%. While administering oral transmucosal fentanyl citrate lozenges also, various patient usage guidelines should be advised to the patient. The lozenge should be placed between the cheek and the gum, and it should be moved constantly up and down and changed at intervals from one cheek to the other. The lozenge should not be bitten, chewed, or swallowed as whole, and it should be consumed completely over 15 minutes. In patients with dry mouth, if necessary, the mouth can be moistened with water beforehand. And we have said that the lozenge should be consumed completely over 15 minutes. We'll wait for 15 minutes. If there is inadequate analgesia, a second lozenge can be used, but not more than 2 lozenges should be used for 1 episode of pain. If there is a requirement of adequate pain relief is not achieved even after use of 2 lozenges, then it has to be reported to the doctor. The lozenge should be removed from the mouth once pain is relieved, and partly consumed lozenges should be dissolved under hot running water, and the handle should be discarded in a waste container and out of reach of children. Coming on to Neuraxial infusion. Neuraxial infusion is a kind of targeted drug delivery. Here we give continuous infusion of medications into the neuraxial space. It is an important option for cancer pain in cancer patients, both when the patient is suffering because of pain, because of the disease as such, and also while performing various diagnostic tests in cancer patients. It is opted when there is refractory pain or there is an intolerance to systemic opioid therapy. The decision for Neuraxial infusion is made on the basis of various criteria, such as the medical status of the patient, the goals of care, the availability of professional and family support, and the affordability for such a procedure. The most commonly used agents for Neuraxial infusion include morphine, hydromorphone, and fentanyl. And sometimes it is also administered along with local anesthetic agents as well. We have two routes of administration of Neuraxial analgesia. We have the intrathecal route and the epidural route. In the intrathecal catheter, it is more commonly used for cancer-related pain. The catheter is typically placed below the level of L1 and the catheter tip is advanced to the location of interest. The life expectancy ranges in patients where intrathecal catheter is used, the life expectancy ranges from weeks to months, and it is often connected to an external pump which can be refilled percutaneously. This is done when the patient is expected to live for around 3 to 6 months. In epidural catheter, analgesia is restricted to a few dermatomes, and the drug dose is often 10 times higher than that of the intrathecal route. Because of this reason, epidural catheter will have more of systemic side effects as compared to an intrathecal catheter. It is an option in patients where the tumor burden will obscure the lumbar axis of intrathecal space, and thereby the intrathecal catheter placement is not possible. It is also used in head and neck cancers, and it's a better option when life expectancy ranges from days to weeks. Here we can see the intrathecal catheter being inserted, and there is an external pump port for drug injection and also withdrawal. And now the common side effects of fentanyl on various organ systems. We have already discussed the effects of fentanyl on various organ systems. In the gastrointestinal system, it will result in nausea, vomiting, constipation, dry mouth, and EPS. In the nervous system, it might cause somnolence, confusion, myoclonus, abnormal dreams, hallucinations, and hyperalgesia. We have already discussed that it increases the tone of various sphincters, and it also therefore it also has action on the urinary sphincters and might result in urinary retention. It has the action of respiratory repression on the respiratory system. We have already discussed that it acts on the respiratory centers in the medulla and results in respiratory depression. It results in decreased cough reflex, and it has an antitussive effect, but the exact mechanism is not known. In skin, it might result in hyperhidrosis and also pruritus. In the endocrine system, it might result in hypogonadism and also will cause immunosuppression. The adverse effects of fentanyl. It will cause respiratory depression, as already discussed. There is preponderance of respiratory depression in patients of obstructive sleep apnea if a high dosage of the drug is given, in case of renal or hepatic insufficiency, and if patient is already having increased levels of carbon dioxide in serum. We have already discussed bradycardia, where it occurs as a result of increasing tone of the vagal nerve, and it also results in vasodilatation as a result of central mechanism where it slows down the vasomotor center, and it will also result in muscle rigidity. The exact mechanism of muscle rigidity is not known. It results in wooden chest syndrome, and it occurs often when the boluses of drugs are administered quickly over a short period of time. Now, the incidence of adverse effects. Very common adverse effects are those which are found in more than 10% of cases, including drowsiness, dizziness, headache, insomnia, nausea, vomiting, constipation, muscle rigidity, which occurs when given through the intravenous route. And common adverse effects, that is, the incidence ranges from 1 to 10%, include abdominal pain, anorexia, anxiety, diarrhea, dry mouth, dyspepsia, visual disturbances, palpitation, sweating, and vasodilatation. And it also has topical effects such as occasional skin irritation and hypersensitivity. The toxicity of fentanyl is it manifests as the extrapolation of the side effects. It most commonly manifests as respiratory depression or CNS depression, and treatment is the opioid receptor antagonist, either naloxone or naltrexone. Naloxone is most commonly used in clinical practice, and it can be administered via the IV, intramuscular, or subcutaneous route. The initial dose is 0.4 to 2 milligrams, and doses can be decreased as per response every 2 to 3 minutes to a maximum dose of 10 milligrams. In case of severe muscular rigidity, as a result of due to fentanyl toxicity, IV neuromuscular blockers can also be used. The reasons for serious drug effects, serious adverse effects, while fentanyl is being used, is because there is a lack of appreciation among patients that fentanyl is a strong opioid analgesic. There is inappropriate use for short-term, intermittent, or post-operative pain in patients who had not been previously receiving a strong opioid. And there is lack of patient education regarding directions for safe use, storage, and disposal. There is lack of awareness of the signs of an overdose and when to seek attention. There is lack of awareness that the rate of absorption of fentanyl may be increased if the skin under, in the case of a transdermal patch, the skin under the patch when it becomes dilated, such as in febrile patients, or if it is exposed to an external heat source. And there is lack of awareness of various drug interactions which can increase fentanyl levels in serum. Coming on to dose adjustment and renal failure based on the glomerular filtration rate. Fentanyl, as we know, we often see and know that it is very safe to use in patients with hepatic and renal failure, but it also requires various drug dose adjustments when the GFR is compromised. In the case of GFR of greater than 50 ml per minute, 100% of the original dosing of fentanyl can be used. If it ranges from 10 to 50 ml per minute, then 75% to 100% of the original dosing can be used. And if the GFR is less than 10 ml per minute, then 50% of the original dose of fentanyl is being used. Coming on to fentanyl versus morphine. As shown in the figure, we can see that with a very small dose of fentanyl, there is more concentration in the central nervous system as compared to the corresponding analgesia that morphine can cause, and it is more concentrated in the vascular system. Because of less concentration in the vascular system, fentanyl will result in lesser side effects such as less constipation, less nausea and vomiting, less peripherally mediated withdrawal symptoms, and also there is little effect on the sphincter of body. Coming on to the algorithm for fentanyl titration that we use in our PCU. The fentanyl titration is often considered in patients with severe pain, in patients where the NRS numerical rating scale for pain is greater than or equal to 7 on 10. It is often considered in patients with intolerable morphine-associated side effects, and also in patients who have a deranged kidney and liver function, and also in patients with significant cognitive impairment. It is also being commonly used for opioid rotation. The algorithm is step 1, where we give a bolus IV fentanyl of 0.1 to 1 microgram per kg, or a dose of 10% of total previous 24-hour IV morphine dose if the patient has already been taking IV morphine, and we continue an infusion of the same rate. And in around 5 minutes, we check the NRS again. If the pain is again great, NRS of pain is again greater than 4 on 10, we repeat step 1. That is, we give a bolus again, and in step 3, if the pain is still greater than 4 on 10, we increase the fentanyl step 2 dose by 50%. And in step 4, what we do is we repeat the step 3. And in step 5, we further see the NRS of pain. And if it is still greater than 4 on 10, we'll review the clinical history of the patient, and we look for concurrent neuropathic pain. In each of the steps, we check the NRS of pain in every 5 minutes. And from step 2 onwards, if at any time the pain NRS is less than 4 on 10, we'll continue the IV infusion at the same rate till a further therapeutic decision is made. For example, if there is a decision to switch to any other opioid, or we'll apply a transdermal fentanyl patch of an equivalent dose and continue IV infusion for 5 to 8 hours. Thank you.
anything? Swati, thank you, Revathy.
Thank you, ma'am. Thank you, ma'am.
Any questions?
Any questions anybody has? No question? Anyone wants to ask anything? They can open their mic. Anyone wants to share the experience of fentanyl transmucosal lollipops, fentanyl lollipop, oral?
I have a question.
Yes, please go ahead.
Yeah, I just want to ask, in case of severe pruritus, patient with already having a pruritus, can we use the patch?
Oh, like Swati, go ahead.
Can you please repeat the question? I didn't get it.
In a patient who is already having a severe pruritus, can we use a patch for them? Because I've got a lung cancer patient with almost the whole left side of lung is gone, and she's not able to take anything orally. Nausea and vomiting is there. And to shift on to fentanyl, she scratches all over the body. She's got severe pruritus. So can we use a patch or?
So in case of pruritus, if you are your patient on morphine, if he is having pruritus or otherwise patient is having pruritus and you want to use patch, I think we can use patch. Yeah.
You can. No, she may scratch off the patch, and that is because she, like when she gets the itching, she really scratches very badly, and I haven't been able to control the pruritus for her.
So ideally, there will not be any evidence, but ideally what we should do that we should pruritus will be a transient phenomenon. So try to address the until the time patient is having itching and itching to this extent that she can scratch this. I think we should continue IV, and once that itching is then
it's a homebound patient, so IV will be a problem to monitor the thing.
And we can use subcutaneous route in.
Yeah, but with the itching and all over the place, scratching, even the subcutaneous, I was wondering whether it is okay. And what will be the best antihistamine to give her to stop this pruritus?
I think subcutaneous will be okay because absorption will be through the subcutaneous route. And most of the time, orally, people give cetirizine, and otherwise we can give Avil injection at home.
Hasn't worked.
Yeah, it works, but we have to find out the cause. Basically, in
cause of pruritus, I am not able to tell whether it's a neoplastic, para-neoplastic phenomenon, or why is she having so much of itching, severe itching. I never seen an itching like that before. And for a short, she says, give me hot water for compresses, I feel better. So normally we say in pruritus, we don't give hot water bath and hot water compressor, but this day lady wants, give me hot water patch, give me comfort, this thing with fermentation with hot water, that feels better for her.
So can I speak, Sushma? This is Dr. Shobha here.
Yeah.
Yes, Shobha, go ahead. Yeah.
So, sorry, I don't know who's speaking, but itching can be due to several reasons. It could be because of high bilirubin. So whether she's got jaundice, if that's the case, then we could try cholestyramine. Sachets, I think it's 4 grams 3 times a day, if it is due to jaundice, if it is due to bile salts. So that's one of the main reasons why people have itching at this time. Second, it could be due to morphine. And have you given morphine to this patient?
Yeah, she has been having itching even before the morphine was started.
Even before. So sometimes ondansetron works well for such patients.
Ondansetron also 8 milligrams are given her daily, but 2-3 days it doesn't.
Okay. Have you tried any topical things like calamine lotion and things like that?
Yeah, calamine lotion temporarily relieves the thing, and after half an hour, 40 minutes again, she starts the itching. And she doesn't have jaundice. She doesn't have jaundice. I do not know whether lung cancer has got any specific this thing on pruritus.
Yeah, so paraneoplastic thing, maybe you could try a stint of steroids for such patients because it's a.
I just started on Dexa yesterday, so I do not know whether it's going to work or not. And any mirtazapine or anything of those things, will it help?
Sorry, which one?
Mirtazapine?
Mirtazapine, yeah. So those are the drugs listed for, often used for itching. And so maybe you can try. If something doesn't work, then you can try the other. Or topical applications like we have this oils which are available, desi oils. Sometimes that brings down itching, like mustard oil and things like that. So it's a counter irritant. So sometimes that works.
Coconut oil has been tried, it has not worked.
Not work. So then you'll have to sedate.
I think it's an intractable itching, and then we should try to find out the first, as Dr. Shobha said, that please stop sharing Revathy slides so that we can see many people.
Yes, ma'am.
As Dr. Shobha said, that we should try to find out the cause, and if antihistaminic, ondansetron and all not working, then we should continue we have to sedate the patient. That's all we can do. But I have not yet seen such patients with itching that we need to sedate such patient. But
no, what will be the best sedative we can use for her?
Okay, so best sedative probably will be the midazolam and
okay.
or diazepam.
Clonazepam.
You want to add something in this question, Dr. Reena or Dr. I can see Vidya. Dr. Reena, you want to add in this? Dr. Jennifer? Intractable itching with the fentanyl.
Hello, ma'am. Yeah, ma'am, this is Vidya.
Vidya.
So, usually, like what Shobha said, first we rule out hepatic, then we rule out uremia. And paraneoplastic itch is very common. You do see it in lung and you do see it in lymphomas also. So mirtazapine has helped some patients. Gabapentin has also helped some patients. And steroid has helped. So we usually go one after the other and see what helps best. So the most difficult itch that I have managed so far has been with lymphoma. And in that patient, a combination of Dexa and gabapentin did help. And mirtazapine helps very well also in some of the
mirtazapine, what dose do you give? And GABA?
I usually start only with 7.5 HS and then step it up to 15 milligram HS. And that's how I start with mirtazapine. And gabapentin, I always start low and then go up. So I start with a TID of 100 milligram and then step it up to 300 milligram TID.
No, I wanted to try Magaba, but I wasn't sure because nothing had worked. So I was wondering whether.
Yeah, so it has helped, and this has helped in my usually non-Hodgkin's lymphoma, or in our lymphoma patients, we do see this, and also in lung because
this is a lung cancer patient. So that's
this has helped so far. But I would love to hear from others because this is really a
can unmute Dr. Jennifer.
There is a topical preparation. Sorry, Sushma. There is a topical preparation of gabapentin which you can try. Topical preparation of gabapentin which you can apply. Maybe that release, and it works well with neuropathic pain for our patients. So that is also available. Maybe
could you tell me the trade name or what is the?
I am sorry, I don't know the trade name. I just put it in the pharmacy EMR, the electronic medical records, and they supply it. So I just put thank you.
I'll try that one. Let's see. Thank you so much. Thank you.
Now, Dr. Jennifer wants to add something. Please unmute her.
Ma'am, she can unmute. I think there's some technical issue at her system.
Okay, so everybody, I think Dr. Stanley, you want to add?
No, this transdermal gabapentin, I think with this lady having such severe itching, no transdermal is going to work because she will take off the patch, with the scratching. So we have to be careful about that.
Yeah.
Okay, sorry, going on to another aspect, quite often, some oncologists would have started the person on a fentanyl patch, and then they come to us, their pain is not stabilized. And so what I would suggest is to remove the patch and start again with the titration with oral morphine, instead of struggling with the patch.
No, she's still on oral morphine, but I was thinking because she's having nausea, vomiting, plus this itching and all added together. I was thinking if something could relieve her of these things, no?
Yeah. No, not this thing was not in relation to the pruritus. In general, I was saying about
Generalized.
yeah.
Thank you, sir.
Okay, Dr. Jennifer,
Can I speak now?
Yeah, please go ahead. Yeah.
Yeah, thank you. Yes, I agree with who was saying that itching is quite a difficult symptom, can even lead to psychological distress and depression if we are not able to address that. One of the other medications, if it is jaundice, and if the patient is not on opioids, is to try can be naltrexone. That tablet naltrexone can be tried.
Okay.
Apart from mirtazapine or gabapentin. So when we don't have an easy issue, then easy solution, then there is a different list of medications you can only try and see which one works. But if a patient is not on opioids, naltrexone in small doses have helped.
She's already on morphine.
She's on. Okay, then that's out of question.
That will not also.
Yeah. So now, so gabapentin is something you can try.
Okay. Dexa, how long and what dose should I give her?
I think, Grace, you should try low dose of dexamethasone. There is no need to give high doses. And if it is not working, you should stop. Dexamethasone, the principal.
Yesterday only started, so I'll wait for 1 day or not 2 days.
And then, yeah.
Thank you very much. Thank you.
Dr. Vidya is saying burst dose of dexamethasone. Vidya, do you have experience of burst dose of dexamethasone in?
Yes, ma'am. We usually give them a shot and start the gabapentin alongside, so that initially the dexa works and then the gabapentin takes over.
Okay.
So that's how we
8 milligrams start, or even
we give
higher?
it as 4 milligram. I start with 4. Again, I don't go to 8 unless there is another indication. I start with 4 and then taper it off, and then after that, within a week or so, and start the gabapentin simultaneously, so that this start acting.
GABA, you start with 100 TDS and then
I start with 100 and then step it up again.
And it's a 4 milligram IV, IM, which
no, I just give oral. If the patient is at home, I would give oral. But if I have the access, then you can give it.
Okay. No, orally I started yesterday, so that's why I asked whether I should shift on.
And be watchful for all the others. Like the fluconazole, Candida.
There was a good article on pruritus by Dr. Twycross quite some time back.
Yeah,
and I remember him mentioning paroxetine. I don't remember exactly. I've not used it, but maybe you could look up that article.
No, paroxetine may not be available in Goa. That's the thing which are commonly used drugs may be there. I'll see about it.
Okay, I think enough suggestions. Grace, is it okay? Enough suggestions regarding pruritus. We should go with the next question.
Thank you so much.
Do you have any experience of using? Anybody has any experience? Shobha, Vidya, anyone, or those who have not spoken till now, of using fentanyl lollipop, transmucosal fentanyl pad, or fentanyl?
Very limited. But in our Indian situation, it can be quite expensive, and a very good alternative is subcut fentanyl.
Shobha, thank you, Dr. Krille.
Ma'am, here, Pravi, we are using fentanyl lollipops quite often, madam. Quite often. Almost we sell 100 to 150 lollipops per day, usually. So
100 to 50 lollipops per day.
100 to 150 lollipops per day are sold usually in our hospital.
Oh, good. So what is your experience of this lollipop?
So we have 200 micrograms transmucosal fentanyl lollipops. So the pain relief is like we say, most of the patients, 60% of them, they have good relief. 40% of them, they say that this lollipop is absolutely useless. This is not showing any effect. I am not feeling any difference with it. But 60% of them, they say that it has good relief, good pain relief. And when it is giving good pain relief, they are very much satisfied with the outcome also.
So what are the indication, Praneeth, when we have morphine and fentanyl injection and patches? What are the indication of using 100 to 550
So when a
lollipop?
patient is on fentanyl patch and he's like we say that he having some oral problems or he's having problems with the deglutition, they're usually not very comfortable taking morphine tablets as per SOSP. They're very comfortable, very much comfortable with the lollipops. And few patients, we start them, they're affordable, we start them fentanyl patch and fentanyl lollipops for SOS pain, even when they don't have any problems with oral alimentation. And they are very much happy with the usage. It is 60 to 70 rupees per lollipop, 60 to 70 rupees for a single SOS dose. So we can use it in
So you
patient to
mean to
patient
say
basis.
this, you are using it for breakthrough pain, huh? When patient is on fentanyl
Yes.
patch and in case, so rather than giving morphine, you're giving fentanyl lollipop, okay?
Yes, ma'am, exactly. We are giving for breakthrough pain.
So how are you explaining them to the dispose? Because whole lollipop, they will not chew and they will not suck.
So yeah, usually we will be using the whole of the they'll be using whole of the lollipop. If they are not using whole of the lollipop, we are explaining them that they should be dissolving the lollipop and in water and then throw that stick, because it is a white color thing which is there at the end of the lollipop stick. It will be dissolved in the water if it is left for more than half an hour, because it takes time to get dissolved in water.
I think Praneeth's children are there. I know that they are very, very young and small. So I think they are.
Sushma, can I add? Sushma?
Yes, please go ahead,
This is
Shobha.
Shobha here. Yeah, so we long back we had used fentanyl lollipop, and it's for breakthrough pain. So we'll tell the patient, we'll take it out from the cover, roll it onto your buccal mucosa twice, and then keep it there for some time for breakthrough pain. Suppose the patient is getting up from the bed to go to the toilet and they have breakthrough pain. That's when we used to sort of tell them, and we'll put it back in the cover, in the plastic cover, and then keep it in the fridge. This is what we tell the patient when they go home. It's like there are I can't remember how many times you can use that and how many doses it is there. So there are specific instructions there how to use it. I'm sure Dr. Praveen would be able to enlighten on that much more. So I don't remember exactly. But outside India, fentanyl tablets are available, which is very useful, and it can be used like buprenorphine tablets. We use it sublingual. Fentanyl can be used as sublingual, so it's like
Sublingual Abstral, ma'am. We have used that also. It is not available in India. A patient from Qatar has got it once.
Exactly. So that's very useful as well when patients can't tolerate morphine with high index of constipation. So fentanyl works patches with the fentanyl tablets. We don't have it in India, so it will be useful for you to sort of influence someone to manufacture that in India, I would say.
So now we have 7
I
more
have a
minutes.
question. She said that the patient uses fentanyl and then keeps the rest of it in the fridge. So how long can he use like this?
Exactly. So I think I can't remember exactly, Dr. Swati. I think it was 48 hours. What do you say, Dr. Praveen? I can't remember how long because I haven't used it since.
Ma'am, we are not advising them to reuse it, ma'am.
All right.
Usually, because usually most of them they will be having pain relief only after 15 minutes of repeated sucking. So that fentanyl thing will be dissolved when they have after 15 minutes. Or if something is left, they will be. We are asking them to dispose it off.
Yeah. Okay.
We are not allowing reuse.
Right.
So we have 6 more minutes. I think fentanyl lollipop we have used only when the pharmaceutical company in 2009 brought first time in India for the trial purposes. And during the trial, I have realized that it is of not much use for our patient because of the cost. Otherwise, it is a very good that in the trial also now there are enough evidence that it is a very good agent for breakthrough pain. It is very potent agent, and we can use it for breakthrough pain, but not for baseline pain or for maintenance of pain. Similarly, the result of the trial also shows the same thing. But again, because of the cost, I think we have not continued using at AIIMS because we were having morphine and fentanyl patches, and we were continuing those morphine and fentanyl patches. So if any last minute comments anybody wants to give, otherwise in the brief, I think we can see that Asif has raised the hand. Asif, please go ahead. Asif from Srinagar. Asif, is by mistake your hand is raised, or you want to say something? Dr. Asif. Yes, please go ahead.
Sorry, ma'am. Mistakenly, I touched this, na?
Mistake. Okay, no problem.
Yeah.
So it's okay. So no, it's okay. You should have. You can say something about fentanyl because you are using a lot of fentanyl in Srinagar. So anyway, we can see that history is not a very old history regarding as far as fentanyl is concerned. It is basically, as Revathy has started with almost in the 1950s, somebody has invented this molecule, and then in 90s, we have started using in OTs and in various places. In 2014, Government of India, NDPS Act was amendment, and everybody has started getting fentanyl patches with the simpler rule. And as far as fentanyl is concerned, in during intraoperative and perioperative period, it is used quite extensively all over India. But as far as pain management is concerned, very few people are using. But I have seen a lot of corporate hospitals. They don't titrate fentanyl properly, and just they'll write 25 microgram, 50 microgram. So this is not. I think this is not the way we should be starting fentanyl. We have to titrate fentanyl either with IV fentanyl or with morphine, and then we have to convert on. So this is the right way. But sometimes it works for 12.5 with 25 microgram patch. But this is also very true that fentanyl is not a very affordable drug for our patients many a times, because changing every third day, and they remain worried that how to purchase this patch every third day, because even a middle class person, it is difficult to find money every third day, 700 or 800 rupees. So again, as far as fentanyl uses are concerned, we should be very cautious in using it whenever required, whenever indicated. Definitely we should use, and indications Revathy has said, when morphine has having a lot of side effects, when there are kidney functions are not well, in opioid rotation. We have used it many a times for opioid rotation, and this is again a very potent analgesic, and we should continue to use, but we should be having a full idea of its pharmacokinetics and pharmacodynamics, which today we have discussed in the lecture. So this is what I want to say. We have 2 more minutes. If last minute, I want to hear from Dr. Reena George, if she can unmute herself, about her experience of fentanyl patch.
Nothing much to add, Sushma. Thank you. Thank you for a nice talk and discussion. Thank you.
Thank you, Dr. Reena. So thanks a lot, and see you next Monday again at 6:30. What I was missing in today's lecture is what are the various meta-analysis, or was there not there Cochrane review or any recent advances, that what are the evidence of using this? Revathy?
Yes, ma'am.
Anyways, no problem. It was a very extensive and very nice comprehensive discussion about fentanyl. And I think a lot of messages you have given, and a lot of messages in the sense, a lot of information, comprehensive information about fentanyl. And it's very good for MDs, because we most of the time we use fentanyl, but we don't go into the depth of it. So thank you very much, Revathy and Swati. Thank you, Archana and Nisha. And thank you everyone for joining, because it's really encouraging to see more than 80-90 people early in the morning on, that is all on Monday. So thank you all those who have joined for the discussion, Shobha, Vidya, Dr. Stanley, Dr. Jennifer, Dr. Reena, and thank you, Dr. Grace, for asking questions, and everyone for contribution. Thanks a lot. See you next Monday before 6:30.